Thanks for staying on The Baby Doctor. This is the show that brings you all the information and knowledge on your baby. Today, I've been joined by Dr. Paddy Ayete, and he's been helping us with all the information we need. It's such a pleasure to have you here. I love talking to you, Doc, and thank you for sharing your knowledge with us all the time. He's with Elemas Health, and much later I'll tell you how to contact him. But Doc, today we're talking about deliveries. It's the real deal. That's the moment we've all been waiting for, the climax of the 9 months, even though it doesn't end in 9 months for a lot of women. But what usually signals baby's readiness is the labor, right? It's different experiences for different women. What exactly is labor, and when do we know we are getting there?
Okay. So for the pregnant woman, usually she would notice a pain in her back, or associated with a tightening of her tummy, which, during pregnancy, later part of pregnancy, you have a little bit of those, but in no particular order. It just comes and goes and comes and goes. But this time, the pain is rhythmic. So it comes, then it goes away. Then you notice that 30 minutes later, it's back again. Another 30 minutes later, it's back again. Then realize the fact that, no, every 30 minutes, I'm having this pain. When it's consistent like that, then you know that labor is starting. The next stage is that the time between the contractions, as we would call it contractions, becomes shorter and shorter. So you notice your tummy is getting hard, and then after a while it gets soft. Then the next time it gets hard, maybe in 30 minutes. But after a while you notice that instead of being every 30 minutes, it's now every 20, then every 10, then every 5. In most places, or where transportation is adequate, would say when the contractions are every 5 minutes, set off from wherever you are and come to the hospital. We say that in the confidence of the fact that labor takes maybe about 10 hours from the first pain till when you deliver. And we say 10 hours because the cervix dilates from 0 dilation all the way to 10 centimeters. It's approximately 1 centimeter per hour. So that is for the typical person. Pain in the back, pain over your tummy or in the lower tummy, and the pain is rhythmic, episodic, and then after a while, it becomes serious business, and they come to hospital. For some other people, however, they don't have that pain to start with. All they notice is
the baby has a
gush of water.
Right.
And so they are the ones who will first notice my waters have broken and there's no pain. Or as somebody told me on Sunday, I'm urinating, but it's not stopping.
Oh, okay, right.
Because that's how she felt when she saw toilet to pee, and all she knew was that the urine is not stopping; it just continuing. Yeah. So that actually meant she had ruptured membranes. So in that case too, we say come to hospital, and our concern is that there's a risk of infection, and we don't want to put anything inside there until we're actually trying to deliver you. For most of those people, once they rupture membranes, give them a couple, after 12 hours or so, within 12 hours, they will start contracting and then they'll go into labor. But because of the risk of infection, we like them to come into hospital earlier so that we can control the circumstances around. So generally, that is labor. There's something that we call show. And show is the release of the mucus plug. The mucus plug is what keeps the cervix blocked so that external organisms cannot continue to enter to affect the baby. When the cervix dilates, the mucus plug becomes loose and it comes out. Okay. And it's bloody, it's blood stained, and it's like a piece of like mucus, and that comes out. That usually precedes the labor. So most women would see that first before later on they start having the pains, before the pains get intense, and before then they have their baby.
Is there an estimated time between when you see the mucus or the show,
yes,
and when you start going into labor?
Not necessarily. Some people's own last days, some people own last only a few hours. So everybody and their...
It appears for women and labor, everyone's story is different. What's accounting for that?
Well, we are all supposed, we know that you have contractions. We know those contractions are painful. But people differ. One, in their perception of pain. So somebody may have a small amount of pain and they are shouting. I used to have a patient who would be doing, aji, 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 aji. Then one time, hand was on her tummy She started contracting, but she didn't say Ajay. Then we realized the fact that, oh, not all the Ajays were proper Ajay. Some of them were fake.
Attention-seeking
Then later
Ajays.
on, she said, oh no, this is a real one, this is a real one. We had a good laugh about that one.
Yeah.
But so some people have a lower pain tolerance.
Yeah.
And so the small amount of pain they have, they make quite a fuss about it. Some people have a higher pain tolerance, and therefore they can withstand a lot of pain and bear themselves in a very ladylike manner. One of my friend's wives, she's a very big woman, came in labor and was lying there in the hospital bed in her jeans in Kolebu. The midwife came and looked at her and said, it hasn't started yet. When it starts, you throw that jeans away. And she truly told me that when the pain started, she didn't give a care. She didn't care about anything. All she wanted to do was to be free. So she indeed threw the jeans away. So then there are those rare people who don't feel pain at all. They don't feel any pain. There's one woman whose first pain was when the baby is about to come out. So if she's in labor on your ward and you don't monitor her, the baby will come out onto the floor. Because the first time she feels pain, it's baby's coming.
Right. Could this be...
And then there's another one I met who has no pain at all. Beginning to end.
Even when the baby
Zero
comes
pain,
out?
Nothing.
Wow.
All she tells you is that, I think it is coming. Then you deliver the baby and she gets up and she's done.
Wow. Interesting, isn't it? But Doc, I'm just wondering if this has anything to do with age, for example, how well you exercise. Because, you know, usually you're told in the olden days when a lady was nearing her time, there's a belief that if you allow her to pound fufu or exert some level of energy, it helps in pushing the baby out. So I don't know if that is in any way related to how someone is able to withstand pain when it comes to labor.
Maybe not pain per se, but the ability to cope. Because the fitter you are, the more resilience you have, the more you are able to withstand the circumstances under which you are in. So a woman who exercises, has got good muscle tone and things of that sort, is more likely to withstand the stresses of that occurrence than a woman who has very little exercise at all. There are things that actually do work, especially for those who want to have their baby to come a little bit quicker. When you're trying to induce labor, you put some medicine over there, and the medicine's job is to soften the cervix and maybe even start contractions. That medicine is called prostaglandin. That same prostaglandin is in sperm.
Okay.
So when the old ladies say, if you want the baby to come quickly, around that time, start having sex, yeah, they were not
so
wrong.
that's not a myth?
Oh, no, it's true. It works. I know a doctor who actually was told by a midwife that take your wife home and go and have sex with her and bring her back because she was post-dates. So the doctor actually listened to the midwife, took his wife from the hospital home and brought her back. She went into labor that night. She was planned for induction the next day. She went into labor that night. True story.
Wow. We're learning some things here, aren't we? All right, Doc. So, I mean, there's a lot of things to discuss when it comes to labor. Is there a right way to endure the pain? And I'm asking this because of sometimes what our mothers tell us and all the things we hear about, how best you can, and even in other countries, you see that maybe the woman is given a soft ball to sit on, maybe allowed to sit in water. Is there a way to do it so that even though it's painful, like you say, it's easier to cope with?
There are coping mechanisms. There are things that we can actually do to help you to withstand the pain. One, having a support person, having somebody who you are familiar with. So a family member, a doula, somebody who is going to sit beside you throughout the entire process. That person too can act as an advocate for you. So that person supporting you and encouraging you throughout the process allows you to, and keeping you distracted, talking to you about various things that will take your mind a little bit off the pain. That person also acts as a coach to help you do what we would have been telling you to do, which is the breathing exercises. That during the contraction, focus not on the pain, but instead focus on your breathing. And if you are doing that by yourself, it gets a bit frustrating and you get tired. If you have a coach who's encouraging you, hey, it's time to breathe now, let's do, and they are breathing together with you, it keeps your mind off the pain and allows you to cope with it, a little bit better. So that indeed plays a significant role. The ball, for instance, the exercise ball, sitting on that ball and bouncing on it keeps you distracted. Also helps widen the pelvis. So it helps, relaxes the pelvis a little bit, give it a little bit more space, encouraging the baby to descend further and faster. And you know, that whole business of lying on your back throughout labor is actually not ideal. It's actually not ideal. Being able to sit on a chair against the back of the chair, with, like so, wrong way in the chair, facing the back, and leaning over the back, and your support person rubbing the small of your back throughout this really helps with the pain. I was telling you earlier about hot water and its beneficial effect. Being able to stand under the shower with the hot water just hitting the small of your back where you're having the maximum pain, and just stay there 30 minutes, 20 minutes, even longer in hot water like that really helps to ease the pain. And then for those who can have a water bath, the fact that you are in a tub or a big bath with hot water surrounding you also improves the way you perceive pain. So all those things help you to manage your pain a whole lot, you know, better. Then of course we've got the medical interventions. We like the toys. So the doctors come, and there are varieties of things that we could do. In the UK, they give you a mixture of gas, a gas mixture, oxygen and the nitrous, that you breathe. And you, the patient, the mother, you control it. So you just, when you feel pain, take a puff. When you take the puff, it makes the pain go down, or the perception of the pain go down. And then you don't need to puff again until the next contraction comes. Then there are other interventions like an epidural, where we put a small tube in your back, and then we tape the tube all the way here. We put in medicine, and then maybe every 30 minutes, we keep asking you about your pain perception. When you think, usually after maybe 3-4 hours, the pain will come down, then they top it up a little bit, so that your pain will be managed until it's time to labor. And there's a one-shot spinal where we put in similar medicine, but in a different concentration in the back there, but that will last for about 4 hours. And you can top it up easily, like you can top up the epidural. So there are various methods by which we can manage pain. You don't have to go through all. Women amaze me how they can actually say, I want to go through this raw. I'm like, hey, are you serious? Me? I'm not doing that. Yeah. It's too much. I'm not carrying this for 9 months and going through that pain too. It's okay. Give me as much as you can give me. Load me.
With interventions to reduce the pain. I think when it comes to the medical interventions, we are getting there. But the other ones you mentioned is where I think generally we are lacking in terms of allowing a support person to be there. Because, Doc, you can imagine in our public health facilities where there are inadequate facilities, we are even overstretched as staff. We don't have the time to pamper and massage you, and you know. So it's interesting that you mentioned the importance of these things, especially for women when they go into the labor ward. But let's now look at the types of birthing methods. I remember chancing on a story about the squatting method. In other parts, I'm told in Israel, for example, it's very used where women don't lay on their backs. Usually they're allowed to use, is there a chair or something of the sort that allows you to sit and push? Just run us through the birthing methods. And
well, what we have here, or is most common here, is you lie on your back. If you're not lucky, the bed is flat. And so technically it's actually against gravity. We are trying to drop something down and we put you on a flat surface. So we have eliminated the advantage of gravity in that process, which is not the way we should do things. But that is what unfortunately exists in quite a number of places. Then we have the inclined, where if you're lucky enough or fortunate enough, the delivery bed allows you to incline, where you are almost in a squatting position, but you're not really squatting and leaning forward. You are still leaning back, but you are up. Your head is up, your chest, your torso is up, and then your bottom is down. And then you allow you to push, and your legs are on stirrups, allow you to push and to deliver. Then there's a squatting method. The challenge with the squatting method is that you need the patient to be high up for the clinician, to be able to go beneath and assist in the delivery of the baby. And because it's technically a little bit challenging for the back of the person who is doing the delivery, if you're an older midwife, you are not very enthused in having to bend like this under somebody, and when I want to push, you're not pushing hard enough. It's not exactly easy. However, for the mother, that would have been the easiest way for the baby to just come out, because in that position, gravity is working at its maximum. She was in the squatting position. Her legs are wide apart. Her pelvis is tilted at an angle that will allow the baby to come out. It's actually physiologically the best method The same thing like they tell us that when you are using the toilet, your legs should be flexed up because you actually, it's a more physiological position. So that would be nice if we could get more people to deliver that way. But the logistics of it and a little challenge that comes with it. But with time, I guess we'll be working on that method a whole lot more. Then there are those who deliver underwater.
Yeah. And we see that a lot.
In fact, from squatting and underwater at the same time.
So in other places, you see home-assisted births where you have a midwife or a health professional. In the presence of family, sometimes a husband who is sometimes in the tub with the wife, and as going through the pain with her and all that. And emotionally, I don't know about whether it actually helps relieve the pain itself, but emotionally, it's such a good support for a lot of women. I don't know how long it will take us to get there as a country. Do you know if people have home-assisted births? I mean, besides rural communities where it almost is a norm.
Yes, it is possible to get. I knew a midwife who was doing home-assisted births in this country. She was doing water births too in this country. So, but it's not very common. And we tend to be afraid of what if something happens. And so, how quickly can you get to a big hospital that can provide you with the right kind of service? Those are the kind of things that give challenges. And because our ambulance services are not too great and our roads are choked with traffic, it makes that option a little bit challenging to offer. However, delivery is actually a natural process, and most people should be able to deliver without too much hassle. And so, if you really think about it, if a woman has had a child before, and the child she's carrying is below, let's say 3.5 kilos, and she's an average-sized woman, the chance of her having, and the baby's coming with a head, and she hasn't got any medical conditions, the chances of her having a challenging pregnancy delivery are really small, or should I say smaller than, the other ladies who don't have those kinds of things. So those may be good candidates to consider having a home birth. But you have to pay for the service of the clinician, nurse, whoever it is, for the entire duration of your labor, and that entire bill is upon your head. It may be a little bit expensive.
Doc, so you just said it's a natural process, and here in Ghana, unfortunately, we have had people classify cesarean sessions as an option for weaker women who cannot stand the pain. We've seen women who say that, my child will go through it. Don't use a knife to, touch her. In she can do it. I did it. She can do it. And then sometimes they force these women into complications that end up, sometimes in the loss of lives. There's also the religious aspect of it where, my pastor says I'll give birth like a Hebrew woman and all those kind of things. What informs what the best option is for a woman in terms of whether to do go through the vaginal birth process or have a cesarean session?
Well, in the olden days, the doctor would look at you and say, after examining 1, 2, 3, 4, I think you should have a cesarean section. Nowadays, it's a collaboration between us and the patient.
Yeah.
So you'd examine the patient, you assess the situation, and you'd give options to the client. Usually, if you think she can give a vaginal delivery, the discussion of cesarean section doesn't really come up unless the client brings it up. If, however, you believe that there are things that you should be careful about, then you would have to have discussions with the client as to the fact that because of maybe your blood pressure and the levels at which it has gotten, we can't wait for the duration of labor of 10 hours. We think your blood pressure crisis is such that the baby needs to come out as quickly as possible because that is the solution to solve your hypertensive crisis. So we offer you a cesarean section because we need to take that baby out quickly so that the blood pressure can come down so that you can live. Because if we wait, you may get into a situation where you may have an eclamptic fit and have a convulsion, you can have a stroke, you can lose both your life and your baby's life, and therefore we don't think it's the best option for you. Let's truncate the process by having a cesarean section. Or we've examined your baby, and your baby's size is too large for your pelvis by the assessment that we have done, and we think it will be in your best interest to have a cesarean section. Now, those kinds of ones, the women always tend to say, I want to try. Then you say, okay, you shall try. Then when they get to 7 centimeters and it's not progressing, Then they say, I want the cesarean section. I want it now. No, you don't have 5 minutes to prepare. I want it now.
And is it possible at that stage, 7 centimeters?
Oh, you can do a cesarean section. 7, 8, even 9.
Okay.
You can do a cesarean section. But the challenge with these kinds of patients is that once they get to the end of their threshold, the end of their ability to withstand, they are very impatient about getting a baby out.
And they may even blame you in case of any eventuality.
Even the 5 minutes you wasted, they'll blame you because she has made up her mind now, do it for her now. Meanwhile, you gave her options earlier on, but it happens. It's life. It's human beings. We all go through that. So, like a big baby is a problem. The baby's position may be wrong. When we're in school, or when I was in medical school, we learned how to do deliveries with the bottom. So the time comes, baby coming with the bottom, you're like, no problem, we deliver with the bottom. Then somebody did a study, looked over 20,000 deliveries and said, oh, babies that come with the bottom don't do as well as baby that comes with their head. The recommendation then became, oh, do cesarean sections for babies that come with their heads.
They come with the bottom?
That come with their bottom. If they come with the bottom, do a cesarean section. So the challenge with that is that more and more people are finishing their training not knowing how to deliver babies with their bottom. So the day you have a baby with the legs sticking out, you're in trouble because you never learned that whole process. And that is the reason why they suggested the cesarean section, that the complications are a little bit more for babies that are coming with their bottom compared to babies that are coming with their head. And so rather than get into that kind of trouble, just do a cesarean section for them. So that, for example, now the recommendation would be, hey, I think we should have a cesarean section because of that. But at any point in time, it's the patient's life and their body. And once they are well aware of the facts, the complications, the risks, and the benefits, and they make their choice, we respect their choice. If we disagree with them, we may ask you to write the fact that, yes, you've explained and I still want to go this way. But at the end of the day, it's the autonomy of your body is something that we respect and respect very, very, very seriously. So after we have our discussion and you've made your choice, we respect it.
So it's a case of planned CS for some women and some of them it's an emergency situation.
Yes.
So somebody can have prenatal care where everything was fine, there were no signs of baby being too big or mother not having the ability because of hypertension issues, but the day has come and the complications set in. And so in that case, if the mother is not able to give you her consent, what do you do as a doctor?
Wow, trouble. Hopefully, during this pregnancy, you have had occasion to have met the spouse. And so you would, at that moment, this is the problem, I need to contact the spouse because she's not able to, we need some help in helping her to come to a decision. So let's say you come to hospital and baby's heartbeat is poor, extremely poor. And then we realize the fact that, and it's getting worse. If you continue watching it, it's going to go out so the heartbeat goes and baby is dead. So you think you have to intervene quickly. And the client, for example, in this example is now, doesn't believe, doesn't understand, still trying to work her way around because of some of these belief systems. If you have access to the spouse, you have a chat with the spouse, let the spouse talk to the client to help her to come to a decision that to be in the baby's best interest. The cesarean section is not because the mother cannot give birth. The cesarean section is that the baby cannot wait till the mother gives birth and still be alive.
Okay.
So it's for the baby's sake. So we like to say that if the baby has a crisis, then we would prefer to inconvenience the mother for the baby to live. You understand? But if the baby does not have a crisis, why should the mother be inconvenienced? She can go through the process, take her time and go through the process as normal. So you try and get the spouse, try and get a relative, try and get people to, speak to her. Because in the example I gave you, time is of essence. And the longer you wait, the outcome gets worse and worse. We think only about the fact that, baby dies. What about the fact that baby suffered loss of oxygen? And later on, baby is born with brain damage, even though born vaginally. What have we gained? Yeah. What has anybody gained from that? It's a distressing situation. I would rather not have it. I've seen an occasion where a mother a woman refused a cesarean section. Refused. Outright. And her mother was outside. They brought her mother. And the mother too said no. And talk. She refused to have the cesarean section. And then the baby died. This was years ago when I was working in a public hospital. The baby died. Then the husband eventually came to visit and was told about the problem. And the woman's excuse for not having the surgery was that she said they don't have money. And the husband came and said, no, I'm wealthy. I have money. The problem is the woman and her mother who have this belief that they shouldn't have, a knife should not cut her. But her story gets worse. The baby still didn't come.
So you had to do the CS
Not me, but somebody had to do a cesarean section for her eventually. What did you gain? It's a very painful experience.
Very.
Everybody was heartbroken because this was unnecessary.
Well, for those of you out there who still stigmatize people who have decided to have a cesarean session for whatever reason, best known to them, I hope you learn something from this and you realize that there's absolutely no point in stigmatizing women, especially if they have to go through this and they choose to go through it, whether it's planned, whether it's an emergency. All we need, like Doctor said, is for mother and baby to be hale and hearty. There is a lot to talk about when it comes to delivery, and Doc and I will be back to finish that up. Thank you so much for staying on The Baby Doctor with me, Bernice Abu-Baidoo Lansah. Today, our topic for discussion is delivery. I'm sure you've learned so much from Dr. Paddy Ayete, and he is with Elemas Health. He has so many years of experience, so much knowledge to share with us, and we are always grateful to have him here on The Baby Doctor. So, Doc, we're talking about cesarean section and natural, well, not natural because, vaginal delivery. But there are, even though there are certain things that women of the older generation do to sometimes make the process complicated for younger women who are trying to, go through the process. Like you mentioned, a mother and her daughter insisting they won't have a cesarean, eventually the child dying, and eventually a cesarean happening. There are those who also have very good stories to tell of how their mothers coached them, especially through the pushing process. So someone says, my mom taught me how to do it, and in 3 pushes I was done. What are the things we need to know to help us have a successful delivery? Because sometimes it appears there's a knowledge gap, especially with the younger generation who try to discard everything that the older generation says because we feel like, oh, please, you're old school. I mean, let's do a thing. What are some of the things we need to know to help us, go through this successfully?
Labor is a marathon. It's not a sprint. So all that shouting that you were shouting when you're 3, 4, 5 centimeters, burning all your energy, you will need that energy when it comes to push. Pushing that baby out may be one of the hardest things that you ever do. When the time comes and you need to push, some people are lucky. The uterus contracts. The contractions are so strong, the baby comes out with an irresistible force. They are the lucky ones. Some other ones, they need to support the contractions for the baby to come out. So conserve your energy. There's really no advantage in all that shouting and screaming. I don't even think the shouting and screaming relieves your pain. So I don't quite get it, what they hope to gain by, apart from creating attention and causing a scene. If you get a chance to have some energy drinks, energy-producing drinks, like drinks that have sugar and things of that sort, please drink it. Sometimes they don't want you to drink too much in case you have a cesarean section. We don't expect you to drink one whole bucket of water. But a glass, a small bottle or 2 of something that would give you energy, something that contains quite a bit of sugar, something, please drink so that you have enough energy for this thing. When you get a chance to sleep, sleep. Sometimes we give you injections for pain relief. My patients say it doesn't really relieve the pain too much, but it makes them sleepy. Please, when you get a chance, sleep. Because there's work to be done. But when it gets to the end, and we say you should push, we want you to use every ounce of strength in your body to push. And when you are pushing, every noise you make through your throat, you are reducing the pressure that should be pushing the baby out. So all that, we don't want to hear. Because every time we hear you, it means the baby is getting less of your energy. You are using part of the energy to shout instead of focusing on the pushing. No, you're not disturbing us. You are just reducing your own efforts.
Okay.
And so we would encourage you to give it your hardest effort. At some point, we tell you, stop pushing. And that's because you are not contracting.
Okay.
Some people will now want to be pushing. When you told them, don't push, it's a waste of energy. Wait until we say push. Because if you're contracting and you add the push to it, you get a better result than if the uterus is flabby and you are pushing by yourself. You don't really go that far. And depending on how they position you, they'll ask you to hold your thigh. Putting your hand under your thigh and pulling it back not only gives you a position that allows you to push harder, but also widens your pelvis a little bit, creating a little bit more space for the baby to slip through. So all these are small things that you can try and do to try and make that particular portion of your work a whole lot easier. And a few rounds of sex before you go into labor allows the cervix to be soft, it dilates faster, it responds better when we give you medication to try and prompt the labor to come, and can actually make your labor shorter.
Okay, you heard it from Doc, not from me. So all you heard the old folks say is not a myth. At least that one is not. Doctors are encouraging you to have a lot more sex when your time is due.
Yes. It's the sperm we need, though, not the long rounds. It's the sperm.
Okay.
So if it's going to do long rounds with no sperm, it's of no use to me.
All right.
We want more sperm.
But Doc, is it the case, though, that when women are nearing their time, they actually don't want to have sex?
Yes.
So it's more of a chore than that?
Yes. It is more of a chore at that particular point in time.
But it's a necessity.
Well, the same way that the woman didn't want to have sex, but when she decided she wants to have a child, she chased her husband for sex every day. That same method. Right. She should apply it at that time. Because I know women who are like, oh, what's for sex, dear? But when you want to have a baby, to call the man morning, afternoon, evening, doctor says you should have sex. The husband is tired first. Hey, doctor says you should have sex. Yeah. The woman she has the baby, then she switches off.
Yeah. And Doc, I like the bit where you talk about pushing through the contraction, because, well, I was coached, but that was a real shocker for me, because that was a real shocker, rather, because that is extremely painful. Because my idea was, when the pain subsides, then you rather push. It makes sense, right? But you have to push through the pain. And there are no words to describe that level of pain.
But it takes your mind off the pain a little bit, doesn't it? Because then you're focused on the pushing.
Right, you're right. All right. This delivery business is not a joke. And all the 9 months of prenatal care, all the medication, all the sleepless nights, this is where it culminates. And that's why Doc is here to give you the tips. And I hope you've learned something, especially on resting, right? Because it's important that you store up energy for, like Doc says, the journey ahead. Doc, in Ghana, there is a sad occurrence of maternal mortality. And sometimes when you hear the reasons, you just wonder if the story would have been different if certain decisions were taken earlier, or probably if the person was in a different jurisdiction. In your almost 2 decades of practicing, what have you found to be the reasons why women lose their lives in the process of giving life?
It's always a sad situation when a woman loses her life. I was telling you earlier that I chose this profession because people don't die. So when somebody dies, it's a big, big, big deal. Where I come from is even a taboo to talk about it, that somebody went to give birth and died. It's not even discussed. It's that terrible. There are various problems that may contribute to this. Some start from the home and the community and in their community, and then the ability to access healthcare, then their ability at the healthcare point to decide that this is what you need, and this is where that service can be rendered. And if you get to that place, whether that service can be rendered at that particular place. So we've got people who have got a crisis at home, and then the decision that, okay, let us go to the hospital, often doesn't come early enough. And because husband is not home, there's no money, There's nobody to take her there, all that kind of stuff. Some people travel long distances to get to the hospital. So by the time they get to the hospital, that delay has resulted in the situation getting worse. You get to your nearest hospital, and the treatment, they either delay in discovering that this is the care that you need and therefore putting the intervention in place, or they are not capable of providing that service and they discover it early enough and now say, oh, you need to go to the big hospital. So then you travel a longer distance through sometimes bad roads, across a canoe, water, bridge has flooded, all that kind of circumstances. Now that it's raining, for instance, we have more of such problems. Till you get to the bigger hospital. The bigger hospital may be overcrowded and may have other emergencies before you got there. So by the time it gets to your turn, it becomes, every time you come out of theater, you're looking as to who is in the worst condition. Let me take that one. Who is in the worst condition? Take that one. If you're not fortunate and you're not in the worst condition, you keep going back and back until you become a crisis, and then yours may not work out. And then there are problems with resources. Blood is an issue. I have learned to operate without needing blood, because I realized that you don't always get blood when you need it. So you have to figure out a way to do your surgeries in a manner that will ensure that you don't need blood. So I rarely transfuse patients. But that is because I have learned to do my best not to require it. And occasionally, you've got a patient who you've done surgery for and her blood is not clotting. And therefore, you need a lot of blood. When recently the former Prime Minister was shot, and they got him like 100 units of blood, we're looking at each other and wondering, where can I get 100 units of blood for one patient in Ghana? In her blood group, 100 units. It's going to be tough. So those are the kind of challenges that one faces, and a lot of times even when you get to the center and they are trying to save your life, they're also thinking of how to save her fertility. When sometimes you should just decide that this person retire, she should go on retirement. And that ability to take that decision early that she needs retirement rather than let me try and save it. All these things.
And that's taking out the whole woman.
Yeah, take out the uterus. At some point, you see, with experience and seeing the calamities that occur for inadequate this and inadequate that, you realize that sometimes the best thing to do is take out the uterus. Remove the cause of the bleeding. Let her live. Yes, she may insult you tomorrow, but she'll be alive to insult you.
I like that.
And for me, I'll take that any day.
But there are also stories of women who, I had one recently of a doctor. I understand that she used the IVF process, conceived, went through the process, gave birth beautifully. Vitals were checked, she was okay, BP was normal, everything, temperature. Before they realized, this lady goes into some sort of fit or seizure, and within minutes she's gone. What leads to that?
I don't have the specifics of that case, but if you say fit or seizure, there's something we call postpartum eclampsia. I cannot say specifically that will happen in this case, but I can give you an example. So eclampsia is when your blood pressure goes up to a certain extent that it causes you to have a seizure. Now, when you have the seizure before pregnancy, before delivery, and you have a seizure after delivery, the seizure after delivery is even worse than the seizure before delivery. The consequences of the one after is worse than the one before delivery. And sometimes you check the blood pressure, it is normal. Everything is normal, or it appears to be normal. And the blood pressure starts rising on your blind side. It may not be a gradual process, so that by the time you check it again, you understand? Or it will be hovering around borderline, just below borderline, then it goes up. And then before you are aware, it has gone up so high to the extent that she has the seizure. If she has the seizure, and during the seizure she vomits, and she breathes the vomit down her lungs, her own vomitus has choked her. And when your lungs are choked, your brain has 4 minutes. And then brain goes, and everything else follows. So it's possible that everything seems okay, blood pressure goes up, and it just goes pine, poorly immediately after that. So that, in this case, for example, something that could have happened. Or when she had the seizure, the way the blood pressure went up, the seizure, in addition to the blood pressure, caused blood vessels to burst in her brain. She had a stroke. But the place the blood vessel burst was a very, very critical part of the brain. Not like it takes away your speech or your left side, but a part that controls everything. You die.
It is a tough journey for a lot of women, but Doc, some of the unfortunate incidents happen to the babies as well.
Mm-hmm.
There are people who have very great reports on how the child was faring, first trimester, second trimester. The child is fine, heartbeat is good, everything is perfect, and then we have a stillbirth. I have always wondered what causes a stillbirth. And sometimes you almost want to question why go through all this hard work and go home without your baby. Yeah. It's very sad and frustrating. What are some of the reasons for stillbirths?
Well, for a lot of them, we don't know. We can check, we can give you theories as to, but we can't tell you that it is this that caused it. Mm. For some of them, there are conditions that the mother had. So if the mother is hypertensive, for instance, they can have stillbirths. Some of them would have, if the hypertension is poorly controlled or there are difficulties in controlling it or it's quite chronic, it can cause the baby to be small in size, a smaller placenta, small nourishment. Baby grows, it's not growing as well. The trick is, how do you know when to deliver? So you're trying to manage it to avoid prematurity, and one day the placenta just says, I'm not going to work anymore. Baby is dead. We've got people who are diabetics. Diabetics are notorious for unexplained fetal deaths at near term. Everything can be going okay, then one day, heartbeat is gone. So these two conditions, at least we know the mother had something that these are related to. But there have been patients that we can't find a cause. There's a lady who everything was doing okay. Then around, let's say 35, 36 weeks, the placenta separated from the wall. You check her blood pressure is normal. Usually that happens due to blood pressure issues. But she had a normal blood pressure. But the placenta separated from the wall. And so the baby wasn't getting oxygen because now there's a gap. The placenta is no longer getting blood to take the oxygen and give to the baby. Baby basically lacked oxygen and died.
But Doc, are there ways as a mother you can tell if there's something happening to my baby, right? Yeah, so that, we can avoid some of these things.
Okay, so every mother should know how her baby behaves. And a mother who is observant will tell you, when I drink Coke, this is how it behaves. When I drink tea with plenty of sugar, if I eat ice cream, this is how it behaves. If I eat yam, this is how it behaves. So any mother who is observant tends to know how the baby behaves. By the way, the Coke is plenty of sugar, so then the baby gets hyperactive. Reasons why you shouldn't give Coke to your young children, especially in the evenings. Otherwise, you won't sleep. It's the biggest mistake you can make.
Sleepless nights.
Oh, you and the baby, you all stay awake that night. Their energy level becomes Superman level. So, but, a mother should be able to tell how the baby behaves based on what you are going through. When your heart rate goes up, the baby's heart rate too goes up. It kind of reflects some of these things. So if your baby normally behaves in a particular way, and you notice a change, please give your doctor a call. Pass by. Let them just check your baby for you. Because there have been patients who have said, I've not felt my baby moving today like I normally feel. They come to the hospital and you check and the heartbeat is really slow. In other words, you caught the heartbeat before it went. Yeah. These are the ones that you want to get them into theater within an hour and taking that baby out. If you can do it in 20 minutes, you'll be happy. Rush to theater. Take that baby out because you are trying to take it out before the heart eventually stops. And those babies like that have been saved and came out very normal. No damage or anything. But that's because they were caught before they went, only because the mother was vigilant. Then there are some mothers too who come and see you, and when you ask them, when was the last time you felt the baby moving? They say 4 days ago. Then they say, why didn't you come to hospital? Oh, I was waiting till my next appointment. So, in fact, I only came today because I saw some blood, so I was wondering why. That's why I came. But she hasn't felt a baby for 4 days. And it was all right with her. There's something we call a kick count, which is a chart that we tell you to keep. And you count from when the time you start counting, how much time does it take you to get 10 kicks? And if you know your average, that is within 4 hours I get 10 kicks, then you know that the day in 4 hours you've gotten 6. Something is not right. You understand? So if we need you to monitor, we ask you. Sometimes we give you a chart to be able to do it. But on average, a mother should be able to tell that, Charlie, today I'm not feeling my baby like usual, and have it checked out. Look, there's nothing better than wasting your time and money to go to the hospital for them to check the baby and they tell you that baby is fine, go. Because you don't want them to tell you, we checked and the baby is not fine. That means we have to rush to an emergency. But the worst news of all is that you didn't check and the baby has passed. And maybe you could have done something.
So it's better to be wrong than
sorry.
sorry.
It's better to be wrong than
So
sorry.
please don't let anyone bully you into thinking that you're being too dramatic.
No,
Because you know, sometimes, especially if you're a first-time mom, oh, these things happen. You know, you hear, why are you being too excited? These things happen.
The midwife has got a machine, it's a small Doppler. She can put it on the baby, find the heartbeat, and we'll look at the trend of the heartbeat. And if she notices that the trend is good, she can tell you that, oh, your heartbeat has been persistently good over like 10 minutes. I think you are being a bit too anxious. It looks good. Or there's a machine we call a CTG that draws a graph that you can actually connect you to, and then it will draw a graph. You can observe the CTG over a period of time, and so the pattern is good, you are okay. And then there are sometimes you look at CTG and say, no, the pattern is bad, and I think we need to intervene and deliver you as quickly as possible.
Well, I hope you've learned so much. I have personally learned so much. You know what? We will be uploading these episodes. Share them with a friend so that somebody's life will be saved. Most importantly, one of the things you should take away from today's episode is that as a mother, as a pregnant woman, always understand what's happening with you, and don't be shy to call your doctor, or don't think that you'll be, called too known or too excited, and so you just ignore some of these important signals that your baby may be giving you. I'll be back to wrap up with Doc, but here are some tips for you today. Hope you learned something from those tips. It's now time to wrap up with Dr. Paddy Ayete. He is at Elimas Health, and he is an obstetrician gynecologist. Doc, thank you so much for joining us today. So your parting words to any woman who is hoping to have a baby, in the process of bringing a child to this earth, or just at the point where they have to push?
Have a baby as early as you can, if you can. You can always do a lot of things in life, but you can't always have a baby. Pregnancy can be a relatively pleasant experience if you get the right kind of support and you follow the advice that has been given to you, and you look after yourself. Know your body, know your baby, listen to your baby, and be your own advocate. If you feel something is wrong, please insist that you are looked at. Labor is challenging. It can be made easier. And if you go about it properly, it is not as bad as the stories as you have been told. And we are looking forward to seeing you with your baby and celebrating you on the next Mother's Day.
Great, I like that. So Elimas Health is looking forward to seeing you as well. If you need any help on fertility issues, Doc is ready to help you. He and his team, well-experienced team. You can reach them on 024 8075568, 024 8075568, or you can locate them at 10A Volta Street, Airport Residential Area, very close to the National Service Secretariat, just down the road, relatively opposite that facility. And so please reach Dr. Paddy Ayete, and he will be there to help you and give you all the assistance that you need. Well, let me say a very big thank you to Azel Vogue for clothing me today. You can reach Azel on these numbers, 0288616161, 0288616161. 61. That'll be it for today's edition of The Baby Doctor. A big thank you as well to Think Media. Anything media, Think Media has got you covered on that. We'll see you again in our next episode. I'm Bernice Abu-Baidoo Lansah. Until then, take care and always remember that babies are special, and that's why we give them all the attention they deserve.